Good morning, everybody, and welcome to today's webinar. We are going to be covering underwriting colon cancer. My name is Andrea Rasser, and I will be guiding you through this important topic today. So let's talk a little bit about what colon cancer is. Colon cancer, which is also known as colorectal cancer, is a type of cancer that will develop in the colon or the rectum. The disease often starts with polyps, which are small growths within the colon lining, and sometimes these polyps can become cancerous over time. Not always. There's oftentimes in underwriting we see polyps that are removed during colonoscopies. They do not always become cancerous. It's just a risk that is out there. Some of the impacts globally that we see. Colon cancer is the third most commonly diagnosed cancer worldwide. It is the third most commonly diagnosed cancer in males and the second most in females. What we have found is the rates of incidence and mortality are higher in males than in females, both incidence and mortalities. What we've also found, which is interesting, is that there is a higher incidence level in the more developed countries. Some of the highest overall rates that we see are in Australia, New Zealand, Europe, and North America, meaning us in the US of A. All right, so some of the things that come into play when it comes to age and hereditary factors. Sporadic colorectal cancer is actually pretty uncommon before the age of 40. However, the incidents do start to increase significantly between the ages of 40 and 50. There is, however, evidence that colorectal cancer is increasing in that under 40 age group. There's a lot of things that could be attributed to that, most of them probably being diet and just lifestyle in general. But what we've also found is that in about 35% of the young adult cases that we're seeing, there is usually a link with hereditary colorectal syndromes, such as Lynch's disease and another one that is referred to as FAP. So there is some link there from a hereditary perspective, but oftentimes it's assumed that it has to do with a lot of the processed foods that we eat these days. All right, so what are some of the key factors that we are finding here? 1 in 23 men and 1 in 25 women will be diagnosed with colon cancer at some point in their lifetime. Age is a primary risk factor. Again, those incidents rising sharply after the age of 50. Family history plays a big part. A history of inflammatory bowel disease seems to be seen often. And then again, those genetic syndromes like Lynch syndrome and FAP, those oftentimes can lead to a cancerous outcome. We've also found that African American men have the highest incident rates along the U.S. Among all the different U.S. racial and ethnic groups. And something that was very interesting to me is that immigration from a low incidence region to a high incidence region seem to have a higher rate of incidence as well. Okay, so some of the common risk factors will include both genetic and environmental factors. Most colorectal cancers are sporadic rather than familial. So it is more often that it's a sporadic finding rather than a genetic finding. Unlike some other cancers where we can almost always link it back to family history, that is not the case with colon cancer. It does just sometimes happen, and there's no real answer for why that may be. One of the key things that we see is a personal history of colon polyps. And so I know a lot of times in underwriting, we'll see somebody get approved other than applied for. They'll come back, standard because there were multiple polyps that had to be removed during their most recent colonoscopy. And a lot of times agents or clients will want to know, well, why it was removed. It's not a problem. It's not cancer. They biopsied it and the doctor said everything was fine. And that is good news. It really is, but it still does increase the risk of that potentially turning into cancer down the road. So that is why a lot of times, even if everything was fine, we don't always see those preferred and preferred plus rates that we would like. Especially when we're dealing with larger polyps. So they do look at the size of those polyps that were removed and then anything that displays a high-grade dysplasia. A family history of colorectal cancer can affect, obviously, your history and what may occur, and it does increase the risk by up to 2 times. And then another thing we see in a lot of colon cancer patients is a history of that inflammatory bowel disease, IBS, colitis, Crohn's disease, so on and so forth. Some additional risk factors are going to be obesity. Our nation is not one to be wonderful health, and obesity does definitely play a part. A history of diabetes with insulin resistance also plays a part, which honestly usually correlates a lot of times with obesity, so that's not totally shocking. Long-term consumption of red or processed meats. That is one reason they think that we are seeing such an increase in the more developed countries is because of those diets. Tobacco use obviously increases the risk of any cancer, but definitely colorectal and alcohol use. So those are some things that are looked at a little bit closer. If there is also a family history and the polyps, you start seeing all these things combined, and we're just increasing our risk there for a negative outcome. So what things will decrease the risk? Some of the things that will help us avoid this in the long run are going to be regular physical activity, staying physically fit, diets that are high in fruits, vegetables, fibers, and I might add non-processed foods. Regular use of aspirin or NSAIDs, that's going to increase or decrease the risk as well. And then hormone replacement therapy in postmenopausal women can also help decrease that risk. All right, so what are some of the common symptoms and findings that we come across in reading our medical records and getting backgrounds from our clients? What we have found is that a lot of times the early stages are asymptomatic. The client has no idea there's anything wrong. They go in for a colonoscopy, and oftentimes that's how it's discovered, is just your routine, age-appropriate, well-visit checkups and stuff like that. But when symptoms do begin to arise, the ones that we typically see are going to be abdominal pain, local bleeding from the rectum, black or tarry stools, local tenderness or pelvic pressure. A lot of times that pelvic pressure can actually be more from the tumors that are pressing into the pelvic region. Just something to think about there. Hematuria or urinary incontinence, constipation, diarrhea, or any kind of bowel habit changes. If they become significant and sudden and long lasting, that can be a symptom that we see. Bloody stools, anemia, and weight loss. A lot of times when we see anemia and weight loss, especially in the older population as compared to the younger, over that 60 plus age, that's where we kind of have to start and wonder why they have anemia, why there's this sudden weight loss. If the doctor has recommended that a colonoscopy done, that's something that the underwriters are going to want to see. And if it's been recommended but not completed, then typically we'll see things postponed if a lot of these symptoms are present. All right, so how exactly do we end up diagnosing colon cancer? Diagnosis is typically made by biopsy during a colonoscopy or from a surgical resected specimen. That's going to be the number one way that they end up actually diagnosing it. The majority of colorectal cancers are adenocarcinomas. And once the diagnosis has been made, then they look at the local and distant disease and the extent as to whether or not it's, spread at all. And that's how they're going to determine the therapy and the prognosis. This cancer is typically staged using the current edition of the TNM staging system. If you've sat in on any of my previous webinars, the TNM staging system is used for a very large majority of the cancers out there today. Definitely not all of them. There are some cancers that use a different staging system, but most use this stage. T is going to stand for the tumor. And what they're going to look for, stage 1 typically means that this has all been confined to the inner layers of the colon. It's not spread at all. It's easily removable. Stage 2 is going to be a little bit deeper. It's penetrating through that colon wall. Stage 3 is going to involve lymph nodes. That N in the TNM staging system, that N is regarding the lymph nodes. And so lymph node involvement means it's spread outside those layers of the colon, and now we're at a level 3. And then stage 4 means that it has metastasized to another site. That is what the M stands for in the TNM staging. And so for the distant metastasis, it's often to the liver and the lungs. Those are going to be the two that we see it spread to the most often. Obviously, it can spread elsewhere. Again, going back to like the tumors pressing on the pelvic region, it can get towards the ovaries, the cervix, the stomach, the brain. It can spread anywhere, but the liver and the lungs are the two most common. All right, so what are some of the common tests and procedures that we typically see or look for? A lot of times we will be looking at the CBC, or the complete blood count. The CEA is a lab test that it's just a blood test. The CEA is actually run a lot of times on insurance exams. It's one that we see on there. Not every carrier, not every face amount, but for some of the higher face amounts and the older age clients, we see carriers that run that CEA automatically on our lab findings. And if that is elevated, that is something that will need to be looked into. Urinalysis, colonoscopy, or barium enema, those are obviously going to be needed if there is something suspicious going on and the doctor's recommended it. Chest x-ray, which is going to be in order for us to look at that potential for distant metastasis and making sure there's nothing going on with the lungs. A CT scan can be ordered. Can be the chest, the abdomen, the pelvis, all the different regions that are most likely to be affected. A bone scan, and then obviously CT or MRI brain scan. So lots of different things they can look at. Not every single one of these tests is going to be done for every single patient. These are just the ones that we oftentimes see. But not every patient is alike. Not every situation is the same. So we don't expect to see all of them by any means, unless the doctor's ordered it, and then we're going to want to see it. All right, so some things that we definitely look for when we are underwriting this, or even in my pre-screens. Once we have a case with any kind of colon cancer history, or even just colon issues and problems in general, we're going to want that attending physician statement with the original diagnosis records. They're going to want to see all of the pathology, and then they're going to want to see regular physical exams, any kind of follow-up that has been recommended, especially after a colon cancer diagnosis. They're going to want to see a follow-up at least yearly. If we run into someone who's been diagnosed with colon cancer, they have maybe a portion of their colon resected, and then they decide not to go back to the doctor for the next 2 or 3 years because they feel great, that's not going to be a good thing. We want to see those at least yearly after that initial diagnosis. And then follow-up colonoscopies. In the beginning, those can be every year to 2 years, depending on what the doctor says. Once things look good for a while, we may see the doctor decrease those to once every 3 years and eventually every 5, and maybe someday back to every 10 years. But whatever the doctor has recommended, the oncologist has suggested, those are going to be what we're going to expect to have access to. Regular complete blood count, lab works again, liver function test. We're going to want to see all of that followed up on in a consistent manner. All right, so let's just say we've gotten through all the treatment. What we have found is that surgery is typically the cornerstone for localized disease. If it's something that's just contained in the colon, a lot of times surgery is enough. Usually once we start hitting stage 3 and 4, and occasionally sometimes stage 2, we will also see chemotherapy. Radiation is more frequently used when the cancer is contained to the rectal area and not within the colon. So there is a little bit of a difference there, and where the cancer is at will help determine some of the treatment. And then when we move on to their survival rates, what we typically see is if someone's at a stage 1, then we typically see 90% survival rate after 5 years. Stage 2, it decreases a bit to that 75 to 85%. Stage 3, it's dropping down to that 50 to 70% survival after 5 years. And at stage 4, the survival rate at 5 years is actually under 15%. It's very, very rare. As a matter of fact, I don't think I've seen it that a stage 4 actually gets approved. Typically, those are going to be a decline. Some of the predictors for the survival rate are going to be based on that tumor stage and any kind of lymph node involvement at the time of diagnosis and whether or not it's metastasized. Obviously, if it's spread to other parts of the body, then we're going to see lower survival rates there. All right, so as far as monitoring this and follow-up, kind of going back to what we said before, after that initial diagnosis and treatment, they are going to want to see follow-ups every year consistently. 5 to 10 years post-treatment with colonoscopies and any kind of imaging that's recommended. And let's see here. So something else that was interesting to me is that the risk of mortality from cancers in the colon, that risk for any kind of reoccurrence is stronger in the first year. But the risk of mortality is less. The longer term mortality from the local reoccurrences in the rectal cancers, though, those remain higher. So the colon cancer has less chance of reoccurrence. The rectal cancer has a higher chance. So there is a difference in, again, where that cancer originated from. Some of the emerging trends in society and the red flags that we see, again, are going to be the younger ages at diagnosis. Again, it's not as prevalent, at 40 and below, but we are seeing a pretty significant increase in the younger ages in the last 10 years. Some of the other things are multiple polyps and family history. Those can indicate that there is an indication of a genetic cancer there. So if we do see if somebody has 1 or 2 colon polyps, there's absolutely no history in their family, the underwriter is going to view that more favorably than somebody who has multiple polyps and a strong family history. If they start to see that there's, a family history of any kind of genetic cancer, or even just colon syndromes, they're gonna look at that a little bit with a little bit more scrutiny there. And then one of the things that is definitely a red flag is going to be non-compliance with surveillance. If we have somebody again who's not going in as their doctor recommended, get that follow-up imaging, get that follow-up colonoscopy. That is going to increase their risk of it coming back and not being able to detect it soon enough and treat it early enough. So we definitely want to see those follow-ups. And that unexplained anemia, especially in older applicants, that can definitely be a clue of possible reoccurrence. So anytime we see sudden weight loss or any kind of anemia in a cancer history, that's going to raise red flags as well. So what are some of the things that you're going to want to ask your clients? You sat down with them, they want to get some insurance, and oops, they mentioned that they had colon cancer. So some of the things you're going to want to know, when were they diagnosed? We want to, month and year. That is going to be incredibly relevant. We're going to need to know the stage and the grade at that initial diagnosis. We're going to need to know when they completed their treatment. A lot of times in underwriting, there's postponed periods, and that postponed period is based on the date treatment was completed. It is not based on the date they were diagnosed. So if they were diagnosed in January of 2000 and they were in treatment until January of 2001, it's that 2001 date is where the clock starts for underwriting purposes. You'll want to ask if there were any lymph nodes involved or any distant sites involved. Did it spread? Did it go to the liver? Did it go to the lungs? Did it go anywhere else at all? These are things we're definitely going to need to know in order to assess it appropriately, to shop it out if we need to, which in this situation, I absolutely would shop it out every time. Just as a side note, always better to shop in the beginning than to be scrambling at the end to find the right carrier. Have there been any signs of reoccurrence? If, the client says I was great for 10 years, but all of a sudden I've lost 20 pounds and my doctor can't explain it and my labs are out of whack, that is not going to be a good sign from an underwriting perspective, and we'll probably want to postpone until all of that has been checked out and cleared up. And then it's good to know, to let us know what that follow-up regimen is. If you have a client, you need to come up to me to shop this. It really helps our case if we can paint the picture for the underwriters and let them know, yes, he's going in every year. This is what they're seeing. Everything's been favorable. His doctor just moved him from once every year to once every 3 years. Like, we're showing positive progress there. And the more of this story we can tell, the more accurate the assessment's going to be and the better outcome we're going to find for your client. All right, so just some stage-based underwriting here for you. I think we kind of already talked a little bit about the stages. So stage 1, typically we see, like I said, this is surgical, typically. And if we're over a year out, we may be able to see standard rating up to a mild rating. It, still could be a couple tables. It really depends on the full picture. And oftentimes we don't necessarily see table rates, we see flat extras. So, you may see $5 or $10 per thousand for 5 years or 10 years. Those flat extras come into play a lot of times with cancer because of the time frames that are specified. And those time frames are getting us past those typical recurrence times, when the chance of reoccurrence is highest is when those flat extras are going to be on there, and then sometimes those flat extras can fall off once we get past those time frames. In stage 2, we usually see moderate ratings. It does depend on the amount of time since the treatment, any complications, again, all the follow-ups being favorable, so on and so forth. With this stage 2, I would typically expect to see flat extras on this. Sometimes it may be a table rate, but again, with cancer, a lot of times I would anticipate a flat extra here at stage 2. Stage 3, we're going to see higher ratings or postponements. At least 2 to 3 years postponed, honestly, sometimes longer. That 2 to 3 out here is a little bit lenient, but we are going to see the higher ratings on this, whether it's table rates and flat extras. We see those combined sometimes, oftentimes, and those flat extras, they can range anywhere from $5 up to $20. I've seen $20 for 20 years, and that's a hefty policy. But that's where we start to see the higher flat extras is going to be in stage 3. And then in stage 4, this is oftentimes going to be a decline. I don't want to give anyone super false hope. I don't know that I've ever seen a stage 4 colon cancer approved. That one's there. It has to be exceptional, perfect. Everything's been amazing. A whole lot of credits being given for this to be approved, even after 5 years. That one's usually pretty hard to place, but never say never. I like a good challenge, and I shop it, and we'll see what we can find if that's what we run into. All right, so some other considerations. Again, most carriers are going to impose a waiting period. We know that. Stage 1 to 2, it's going to be a 1 to 2 year waiting period. Stage 3, typically 3 years minimum. And then stage 5 or stage 4, it's going to be over 5 years for sure. All right, some other things they're going to look at is, again, that tumor grade and margins, those CEA levels, which again are just blood tests that the insurance company runs that doesn't require anything extra of the client. Typically, it's a tumor marker. It is not specific just to colon cancer, by the way. The CEA level, this tumor marker, it is actually indicative of many possible tumors that it could be a lot of different cancers. It's not specific to colon cancer. It's just one that is linked highly to colon cancer. And then in the genetic predispositions, those colorectal syndromes like Lynch disease and FAP, and then again, follow-up compliance. That is also always going to be key with any medical history, but especially cancer. All right, so let's explore a couple real world scenarios. One that we had here recently was a 55-year-old male. He was diagnosed with stage 1 colon cancer. He had it surgically resected 2 years ago. He has had no evidence of reoccurrence. He has been consistent with all of his follow-ups. He's been seeing his doctor, doing his imaging, doing his blood work. Everything's looked good. He's staying in good shape. He's got a healthy build. He's a non-smoker. Our likely outcome on this one's going to be standard to table B. It depends on the carrier. That obviously no two carriers are created equally. They all see things a little bit differently, but we should be able to get an offer on that somewhere in that standard to table B range. And for our second case, this young lady was a 62-year-old female. Hers was a stage 3 cancer. She did have surgery. She also had chemo completed 1 year ago. She is still under follow-up care, seeing her physician annually. And on her last visit, her CEA was elevated. And with that, we unfortunately did see postpones for the next couple of years due to that high risk of reoccurrence. But it is something that if the doctor follows up on that CEA level, continues with the imaging, and things go well, then in a couple years, we may be able to get her something in the way of a policy. But right now it was still a postpone, so we were limited to accident only or guaranteed issue coverage. And with that, how can IAMS help? Well, we do have these handy dandy fact finders out on our website. They are at iamsinc.com. We do this health screening questionnaire that is out on our site is very broad-based. It covers everything from driving history, avocations, financials, just overall medical history, foreign travel. It covers a wide range of things. And so if you're meeting with that client for the first time, you can, send this to them in advance to fill out and kind of get an idea of what you're walking into. And then we can discuss what things we need to know in order for me to best shop this out for you. We also on our website have our NAILBA guide. Apparently that's the next screen. I apologize. You can shoot me an email and I can pre-screen this. You can send it to Andrea@IAMSinc.com, or you can also just send it to prescreen@IAMSinc.com. The more information you can give me, the better, and that will allow us to shop that out. We also, once I find out what our best carrier is going to be, then we can work side by side with the sales director to run any illustrations and work on advanced case design and make sure we get the best policy possible for your client. On top of our health questionnaire, we do also have a NAILBA guide, and that has ailment-specific questionnaires. So there is one specific to colon cancer. So if you have a client who has colon cancer, breast cancer, heart attack, diabetes, whatever the case may be, we have a specific questionnaire just for that. So you know that you're getting all the information you need to provide to me to shop this. And just remember that it is a little time consuming on the front end, yes, but it can save so much stress and energy and time on the back end. There's nothing worse than having to go back to the client and start over with the whole new carrier because we picked the wrong carrier the first time. So never hesitate to reach out and find out who might be the best match. And with that, we invite you to follow and like us on Facebook and LinkedIn, and feel free to call us anytime. And I sure appreciate you joining us today. Thanks so much and enjoy the rest of your Monday.